With more than 270 million people stretched across 17,000 islands between the Indian Ocean and the Western Pacific, the Republic of Indonesia is hardly immune to health challenges. It's no stranger to outbreaks of infectious disease and has worked to maintain its status as polio-free while eliminating measles and rubella. At the same time, the country's population, which has on average gotten older, also contends with the human and economic costs of non-communicable diseases, such as cardiovascular disease, diabetes, and cancers. Having a geographically diverse population and not enough doctors, nurses, and healthcare providers to reach services in all of the country's 83,000 villages, this upper middle income country has placed a strong emphasis on health system strengthening, improving access to primary health care, and prioritizing a focus on child health and vaccine-preventable diseases. During the COVID-19 pandemic, when countries around the world saw immunization coverage drop due to the suspension of health services and diversion of resources to outbreak response, Indonesia was able to provide children who had never had vaccines with first-time access and to introduce new vaccines, such as the pneumococcal vaccine and the human papillomavirus vaccine, which prevents cervical cancer. At the end of 2024, following years of having received support from Gavi, the Vaccine Alliance, to procure vaccines and introduce new ones, Indonesia made a commitment of $30 million to the organization's next phase of work between 2026 and 2030. On today's episode of the CommonHealth Live, I'm joined by Minister Budi Gunadi Sadikin, who has led Indonesia's health department since 2020. We'll discuss the country's experience in strengthening primary health care, improving immunization coverage, and extending services for non-communicable diseases. And he'll share his thoughts on health financing and how low and middle income countries can focus on mobilizing domestic resources and building partnerships across sectors to prevent disease outbreaks and address non-communicable diseases in the current global health context.
This is the CommonHealth from the CSIS Bipartisan Alliance for Global Health Security, engaging senior leaders on questions of how to address our common health security challenges in this post-COVID moment.
Welcome to the CommonHealth Live. I'm Katherine Bliss, Senior Fellow and Director for Immunizations and Health Systems Resilience within the CSIS Global Health Policy Center. Today, I'm joined by Minister Budi Gunadi Sadikin, Minister of Health for the Republic of Indonesia, who is here in Washington this week. Minister Budi, welcome to CSIS.
Yes, Katherine. Nice to see you.
Now, I know you're in Washington this week for the World Bank spring meetings, when finance ministers from around the globe gather to discuss and debate all manner of topics. But the big theme this week is jobs, the path to prosperity. Now, you've previously served as Deputy Minister for State-Owned Enterprises, and you have a background in banking and financing. So I want to start by asking you, when we're talking about jobs or employment as a means of lifting people out of poverty, why is it important to think about health and healthcare programming, healthcare services as investments in economic well-being? And what does it change when we think about investing in people's health as opposed to just thinking about health activities as expenses that have to be kind of mitigated?
First, I would like to put some disclaimer because my background, I was a nuclear physicist working 30 years in banking, so mostly on economics matter. In the last 5 years, suddenly the president asked me to jump into health with a zero background in healthcare knowledge. So talking about jobs, my president have an ambition Indonesia to become high-income country. And the definition of high-income country is very, very clear. It is about 14,000 GNI, gross national income per capita income. So for people to have income, definitely they have to have jobs. So that's why job is very important in the discussion of in the World Bank meeting. They need to have jobs. Indonesian people now, the average income is around 4,800. So we still have to almost triple the average income of our people with better jobs So it can increase and break the minimum income standard for a high income country, which is 14,800 US. So another question is, what kind of people that can have a pretty good jobs so that income level is not 4,800 like the average Indonesian now, but close to 15,000. So my answer is very simple. There are two conditions. First, the people has to be smart and the people has to be healthy. So if you are not smart and you are not healthy, that it's impossible for you to get that 15,000 per annum jobs. So that's why for whatever they are talking, I always not argue, but persuade my Minister of Finance, wherever you spend your money, including the World Bank president, make sure you spend enough money to the education sector and the healthcare sector, because this will guarantee that people will have proper jobs, not only normal jobs or underpaid jobs, proper job so they can earn at least 15,000, and that will make them eligible to become a high income country. And I always argue that health comes first, then education. And my argument is to my friends, Minister of Education, because the education system usually starts in every country at the age of 7, and it ends maybe PhD 35, 40. But for me as a Minister of Health, I have to take care of the babies before it was born, 9 months. So minus 9 months and until the people die, United States, maybe the average life is 79 years old. So my coverage is much earlier and much longer compared with education. So that's why don't forget, allocate your budget enough and spend your money in healthcare sector.
So you have healthcare and education, really going hand in hand. Healthy people can study, they can work hard, they can develop,
they can get jobs,
develop new innovations and everything else. But also the healthcare sector can be an engine of employment and work as well. You assumed your role as health minister after a career in banking in 2020 during the global pandemic, and despite globally, overall challenges with global immunization coverage, and we've all seen those graphs where there was really, a dip after 2019 into 2020, 2021. You and your colleagues really worked to increase access to routine immunizations for zero-dose children and under-vaccinated populations, while at the same time really prioritizing and devoting attention to cardiovascular disease and other non-communicable conditions. So I wanted to ask you to say a little bit, in the context of that crisis of the global pandemic, how have you and your colleagues, coming out of that, really sought to assess and forecast the nation's health needs, kind of looking at the goals of, is it Indonesia 2045, or, the goal of becoming a high-income country, kind of looking ahead several decades, really looking at the demographic situation of the country now. How have you kind of assessed and forecast the nation's needs and then, really sought to kind of develop a set of priorities over the last 4 or 5 years?
So we have two issues if we are talking about the future. First is technical issues about the health itself, and second is the financial issues. How can we finance this initiative? Talking about the first one, the technical issues. Now, to be honest, when I joined, we haven't got a real strategic plan long-term on how would be our condition epidemiologically in the next 25 or 30 years. Because our demography is changing. Now the average life of Indonesian is 72 and most likely will increase to the average Asians will be 76, 78. Then that profile will need a different treatment. Technical healthcare treatment. Like now we have around 4.8 million babies every year. It's more than United States. It is almost equal to a country called Singapore. So we have one Singapore every year, new Singapore because of the new babies. So we need a lot of child specialists, OBGYN specialists. But now in the last 5 years, the numbers of elderly in Indonesia is keep increasing. is getting equal with the numbers of below 5. So that needs a different technical treatment, right? Because these people, we don't need child specialist or a BGYN. This need a cancer specialist, heart disease specialist, or stroke specialist, because of the burden of disease are different. So what we are doing now, we are working with International Health Matrix Evaluation. This is an organization based in Seattle, and they help many countries to picture the burden of disease is the next 30 years. So this institution opened an office in Indonesia to help us forecast scientifically what will happen in the next 30 years based on our epidemiological evolutions. So now we understand, oh, okay, this is the type of people, this is the type of disease. Now the second thing is how to fund them, because it is very, very expensive. I always like to use real numbers as a banker. I give you an example. In Indonesia, the average health spending per capita now is 140. Our outcome, 72 average life. Our closest is Malaysia, 76 average life. They're spending 300 US more, around 430. One of the best in ASEAN is Singapore, 84 years average life, and they're spending 3,000 US more than us, around 3,300. So can you imagine? I'm now 61. So Indonesian population are aging. Assuming in the next 5 to 10 years we reach a Malaysian level, 76, and our healthcare system as efficient as Malaysia, which is we are not, but assuming we're as efficient, so we will spend each person increase by 300 US, similar to the Malaysian, multiplied by 280 million, 84 billion US additional every year. We are now only spend 40 billion US every year. If we go to Singapore level, in the next 20 years, we need to add additional 840 billion US. 3,000 US multiplied by 280 million. 840 billion US every year. We are now spending like 40 billion. If we go to US level, US 79 years average life, you spend 11,000. We need 2,100 billion, 2.1 trillion US
That's
every
a lot
year.
of money.
We need a lot of money. So then how can we sustain this? When I see why is Singapore 84 years average life, they only spend 3,300. South Korea 84, they spend 4,000. Japan 84, spend 5,000. US 79, spend 11,000. You know the difference between this country. If like the Singaporean, if your strategy is cure sick people, it will be very expensive. But if your strategy like the Singaporean to keep people healthy, then it will be very, very cheap. So that's why Indonesian strategic programs now, healthcare programs, is not focusing on to cure sick people. Don't wait until you are sick, but to keep people healthy. And to keep people healthy, you need to spend money more on promotive and prevention, including screening, immunizations, and also education to change your lifestyle. So I do hope, Katherine, you are keep healthy until the time God called you to meet Him. And that is, you don't have to be sick, you just go there and see Him.
Well, and so, I mean, you have really placed a strong emphasis on primary health care, right? I mean, immunizations has been, a core element, but I believe you've also expanded health insurance and people's access to some of those prevention methods locally in their local clinic, or so that people don't face all the barriers that they might need to in terms of transportation or waiting to get in for these longer term kinds of appointments. There are a number of big moments on the global agenda this year. I mean, obviously got the spring meetings right now and the World Health Assembly coming up. But in June, Indonesia has committed to host the second global forum on cervical cancer elimination. And then the Gavi replenishment is coming up also in June. And then in September, we have the fourth high-level meeting on prevention and control of non-communicable diseases. So kind of both ends of that lifespan that you were talking about. I mean, really focusing on the prevention, but also really addressing some of those longer-term chronic diseases over the longer period. I wanted to start with the forum, I guess, coming up in Bali in June. And I know that at the first global forum, which was held in Cartagena in Colombia last year, Indonesia reaffirmed goals set out in a national action plan on cervical cancer elimination, and then committed to hosting the second global forum. And I wanted to ask you to say a bit about the country's experience, really developing this action plan, focusing on, the kind of the three elements of the, scaling up vaccination for HPV on the one hand, but also diagnostics and treatment. And, really just ask you to say a bit about, the inspiration for, really offering to host the second conference and what you're hoping to see come out of that.
First, I have to thank the U.S. government, but I will let you know why I have to thank the U.S. government related in this cervical cancer elimination programs. So for non-communicable diseases, or NCD, these are now the number 1, number 2, number 3, number 4 cause of death in Indonesia. Number 1 is stroke, 300,000 every year. Number 2 is heart disease, heart attack, 250,000 every year. Number 3 is cancer, 234,000 every year. And number 4 is kidney problem. It's slightly below 200,000 every year. Tuberculosis as an infectious disease kills around 136,000 every year. So cancer number 3, and when you rank the cancer, number 1 killer in women is breast cancer. Number 2 is cervical cancer. And what amazed me, in many countries, the cervical cancer that kills women, in every country, including the United States, is going like this. Indonesia is going like that. So I said, why? This is a major killer to Indonesian women. I don't want to see my Indonesian women die unnecessarily because we don't have a vaccination in 2022. So that's why I said, this is ridiculous. Every other country has done it. So we launched a vaccination program, national, in 2022, full-blown in 2023, and then during APEC meeting hosted by the US, and then Secretary Becerra, at that time, a friend of mine, invited me, Budi, we are also pushing this cervical cancer programs, and we have grants. So do you want to have something? So during APEC, we can announce something. And then I took the grant from the US government and create our national cervical cancer elimination strategy for the first time. And we studied that the best in the world is Australia, Canada, and Malaysia. And of course, we have ambition. Let's do as good as the Australian, saving Indonesian women's life. We have more than 100 million women in Indonesia. Why they have to die unnecessarily because of cancer while we already have the vaccine? So we have put a very high ambitions. We will spend between 2024 to 2030 around 900 million for vaccinations, and then 2.1 billion for screening, HPV DNA screening tests, and the 10,000 primary care, and around another 1.1 billion for treatment. So we set up the plan. We committed ourselves to 2.6 billion US from our budget, and we are looking for 1.5 billion for grant or loan. So that's why I come to the World Bank asking whether you can fill in the gap. We put already the money. We are not low income country, so we can commit something. But I want to do it faster rather than to wait 15 years, 20 years, and my Indonesian women die unnecessarily. I want to press it down to 7 years or if possible 5 years. Of course, then I need more money because the money that I have to spend in 15 years, now I have to spend it in 7 years. So I need more money, but I think it's very good investment because it will save Indonesian women's life. So that's why while doing it, then I'm very involved in the cervical cancer discussion. I know that the Gates Foundation sponsored this event, and I said, why don't you do it in Bali? I think that will be an interesting place, after Cartagena. And everybody vote for Bali, so we will have the event in Bali next year.
So I know one of the challenges that was talked about a little bit in Cartagena and certainly elsewhere is the challenge of reaching adolescents with vaccines. I mean, it's one thing to reach children under 1 or under 5 because their parents are, taking them to the clinic or they're going to get the shots. But once you have adolescents who aren't routinely in the health system as much as younger children, it can be more challenging. And then, of course, if you're trying to reach the older cohorts, who to kind of catch up with kind of older teenagers or, young women, sometimes, they're really not in the health system much at all. What has been the experience in the country in terms of kind of reaching those populations that are not routinely in the health system?
So you're right. This HPV vaccine target is not children. It is adult. And we have 4 cohorts in our plan. The first cohort that we are running now is women at the age of 11 to 12. And then the second cohort, women age 15 to 16, just before marriage age in Indonesia. And then the third cohort will be women 20 to 21 to cover someone is already late because we started the program just in the last 2 years. And the fourth cohort is boys. It is the latest advancement because everybody told me because boys can transmit the disease to the women, so we need also to vaccinate the boys. So these 4 cohort before the plan is 10 to 15 years. But again, I said, why 234,000 die because of this? Maybe for cervical cancer it's slightly below 100,000, but they're all women. Why I have to wait for 10 to 15 years, So that's why I would like to squeeze it down to between 5 to 7 years. And then we can save a lot of lives. The issue is only money. The money that we have 4.1 billion in 15 years, then I have to have 4.1 billion, in 5 years or 7 years. But this is something, in my view, it's my job to justify, to explain to the Minister of Finance, explain to the World Bank, that we need the money to save a women's life.
So speaking of money and financing, I mean, certainly, one of the things that we've seen globally over the past couple of years is,
sorry to interrupt, Katherine. I forgot to answer your questions. And it is surprising to me. We execute vaccinations over here. This HPV is the most well accepted. So maybe the education system is already out there. So Indonesian women understand, hey, if you don't get this vaccination, you can get cervical cancer, and if you know that it's really bad. If somebody got cervical cancer, the way they're sick and the way they die is extremely ugly. So Indonesian women understand this. So the pick-up rate is above 95%.
Oh, that's
very, very, very high.
Yeah.
So, and it's because of their own interest. They're really willing to take it because they don't want to get this disease.
So the education system has played a role in helping to generate information, but it sounds like also civil society, or at least there's advocacy among women to say, look, you may know someone who has experienced this, or they are aware and kind of talking to each other about the importance of taking it on. Certainly in recent years, Gavi, the global alliance or the vaccine alliance, has played a strong role in kind of revitalizing global focus on HPV vaccines. There was sort of a drop off during COVID, but has really kind of encouraged kind of renewed focus on that, along with kind of the big catch-up to try to close the gap that opened up during COVID. In June, Gavi will be kind of hosting its, having a replenishment conference, and is seeking $9 billion for the kind of 5-year period from 2026 to 2030, really to continue supporting the low-income countries that are, that continue to be eligible for Gavi's support. Indonesia, at one point, was a recipient of Gavi funds, and I think more recently at the Gavi retreat, which maybe you hosted, was at the retreat in December last year, made a $30 million commitment as a donor to Gavi. But despite that and other commitments that other countries have made, certainly the reported cuts to foreign assistance among some of the major donors, including the United States. But, we're also seeing kind of tightening of foreign assistance across the board from many European countries, as well as they focus on military, issues and other conflicts, raise questions about whether Gavi will be able to meet those goals, at the replenishment coming up in just a few months. So I wanted to ask you to say a bit about, the elements of the Gavi model that you find most compelling. It's been celebrating its 25th year, right? It brings together public, private, and civil society groups. So what are the elements that you find most compelling? And could you say just a little bit about this process by which Indonesia, kind of took that experience of having, really worked closely with Gavi over many years as a recipient of support to really kind of moving to this new role?
I will share two things about this. First is about Indonesian involvement with Gavi and how come now we are contributing 30 million instead of receiving a vaccine. The second one is about the Gavi model, the replenishment, because I sit at the board of Gavi also. So I sit at the board of Gavi, my deputy minister sat at the board of Global Fund. These are the two largest global health fund, and we are very lucky that Indonesia was invited because they need to hear the voice of a country like Indonesia. So first about Gavi, before the pandemic, actually our relationship with Gavi is very low, the connections, but after the pandemic we realized that we have money. Actually we are middle income country, although lower middle income country, but we don't have access to vaccine. And Gavi is a global institution that provides access vaccine at the affordable price. We can pay. We don't have to ask for free vaccine like low income country, but we cannot access the vaccine like the high income country because they have a lot of money to pay. So of course, logically the private sector will send it to the high income country. So that's why we deal with Gavi. We got access from Gavi, and then the good thing is, many developed countries at that time buy so much vaccine, more than they needed, maybe 5 times or 6 times the population.
You're talking about the COVID vaccine.
COVID vaccine.
Yep.
And at that time, they just realized there is an expiration date of vaccine and they don't want those vaccines to expire in their books. So they dump the vaccine in Gavi with a very short expiry date. 3 months, 1 month, or 2 weeks. Gavi gave it to the African countries. Of course, that is very logical. The problem is, they expired in these African countries. And then Gavi looking for countries that can absorb many vaccine and deliver to the jabs, to the arms of the people. And Indonesia at the time, we can do 2 million jabs per day. So when Seth Berkley at the time, the CEO of Gavi asked me, Budi, I have 10 million. But the expiry date is 2 weeks. Can you do it? No, send it to me. Why?
No
because
problem.
I can finish it in 5 days. 5 days, because we can do it quickly. Then, without realizing the figures. So I got all the good names, Pfizer, Moderna, you name it, Johnson & Johnson, Novavax. I have had those vaccines for free, And I calculate the amount is north of 1 billion US. North of 1 billion US. And, it is the feeling that I want to share with many countries. Hey, this institution, without asking anything, help me to save my people's life. 1 billion US. And now it's the time for us to give back to them. I think that makes sense. It's a good gesture. It is a good ethics, to just give back to them. So they need money. We are not as rich as any other country, but we want to give an example. 30 million, why? It is an appreciation for the members that have received and then give it back. It also can be seen as an example. Hey, even Indonesia, middle income country contribute 30 million. Why don't you contributing to Gavi? Because you are a much richer country than Indonesia. Your GNI per capita is about 4,800 like the Indonesian. But I do hope this can also carry a good message to other countries that please help this institution because this institution was a great institution. That is the Indonesian story. Number 2 is about the replenishment itself. I sit at the board of Gavi. I saw what they did. and I'm very passionate in it because it saved millions of lives, including the women's life of HPV. They're working with new vaccine for malaria, for tuberculosis, for a country that not as lucky as Indonesia, because the way I see the healthcare financing, the low income country should have grant. That is the first level, and then they will move into the second level where they have concessional loans. It's good to also to push the country. You cannot receive grant forever, right? You also have, that is your obligations, our obligation, Indonesia's obligation to increase the quality of our people and country. Then we move to concessional loan, and hopefully after that we can be independent and sustainably maintain the healthcare programs with our own money or borrowing from commercial loan. But this pathway should happen, and I would like to convince many other countries. I'm afraid that many countries now use the money, their budget, to buy more guns rather than to spend in health. That is very, very sad. As a Minister of Health, I would like to persuade why you buy guns that the purpose is to kill people rather than you buy a vaccine that the purpose is to cure people, to make people healthy. I think that is a good cause. So that's why I said, please, other countries, don't reduce your contribution to Gavi. Because why? This group of people, Indonesian is in the second group, this group of people that needs grant of vaccine. When you take this grant, this money off to buy guns rather than to buy a vaccine, millions and millions of people globally will die. Millions of people globally will die. So this is the occasion that, thank you for CSIS that I can share this view as the Minister of Health of the middle income country, talking on behalf of the lower income countries.
Well, and what you've laid out, is really, in part, I think, around the importance of the transition model, right? That so countries may start out paying 20 cents per dose, and then as they economically develop, they begin to pay more and more. But there is that vision towards sustainability and self-financing that has been, so critical and really refined over many years with Gavi. And of course, with the malaria vaccine, as you pointed out, there's an opportunity for the Global Fund and Gavi to work together on issues related to malaria. So, of course, there's several replenishments happening this year. So
by the way, Global Fund replenishment also will happen this year. So Global Fund and Gavi will happen this year, and that will be tough.
That is going to be very tough. I want to ask you, kind of looking ahead to September then, there's the fourth high-level meeting on non-communicable diseases. And of course, there was one, the last one was 2017 or 2018, and kind of going back to the early 2000s. And, countries have really come together around the challenge of NCDs as populations have gotten older, and as just the burdens, as you pointed out, of stroke, kidney disease, cardiovascular disease, diabetes, and others, have really become apparent that these are long-term conditions that are economically challenging for families, for households, and ultimately for society. When it comes to kind of global meetings like this, we'll see governments come together with private sector and civil society. I wanted to ask you to say a little bit about, where you see the role of the private sector in really kind of moving things forward on the NCD agenda in particular, and what you hope to see come out of this meeting in September, kind of, looking ahead towards, the next few decades as these conditions become even more prevalent in society.
So I work for a private sector in 30 years, so I know exactly what private sector is. So first, I would like to answer the private sector role, and second, I will talk about the NCDs. So Indonesian economy, when the first time Indonesia established in 1945, if you see the Indonesian GDP, maybe the contribution of the government is 60 to 70% of it. The overall GDP of Indonesia depends on the government budget. Now, the government budget only contributes 17 to 18% of Indonesian GDP. So you understand the rest is coming from private sector. So whatever we do as a government, if we would like to move the needle in every aspect, economic, health, energy, etc., you have to understand, that at the current situation, 80% is dependent on private sector. Our job as a government is to create regulations that give incentive to this private sector, to use their balance sheet and grow the sector that we want them to grow in, to serve our people. And our second job is to make sure, because private sector, of course, the motive is for profit, is for money. So they don't abuse the system and take unlimited profit, squeeze the profit out of the people. So that is the only job. So, but we have to realize as a government officials, we need the private sector. Forget it. You cannot fix the problem only with government, because your contributions, your part is very, very small. And to do that as a government officials, we have a very powerful man. We need to write a regulation that incentivizes the private sector to work. But of course, tell them, hey, don't do stupid things. I know that you cannot do stupid things and make our people suffer. So that is on the private sector. On NCD, these are chronic diseases. Stroke, heart disease, cancer, kidney, chronic diseases. I'm not a medical doctor again. I'm a nuclear physicist. But chronic disease means you will not die because of cancer right away after you get the first indications. No. You get the first indication, and because you don't treat this condition, it gets chronic after 5 years, 6 years, or 7 years. So the key here is you have ample of time to improve your health conditions, to improve your chronic disease condition before actually it become unbearable. So that is what we are doing, our approach. If you treat your chronic disease at the end, then it will be very expensive, quality of life is very, very bad. Like example, in kidney problem, in Indonesia, we do a lot of hemodialysis. You have to go to every week, 2 or 3 days to the hospital, stay for 4 hours, 5 hours doing nothing.
Yeah, it's really...
But in this one, usually you can identify 5 years earlier when your blood sugar level is high. Your HbA1c is above 5.7. So what we are doing now in Indonesia is, instead of attacking the chronic disease at the end of the period, we are doing it early in the period. We do massive screening. And cardiovascular disease, heart attack, stroke, and kidney disease, the top 3, can be controlled easily if you control your blood pressure, hypertension. It should be your blood pressure 120/80. Your blood sugar, your HbA1c should be below 5.7, and your blood lipid or your cholesterol level. Ideally, your LDL level should be below 100. If you control these 3 and you are above, you can go to primary clinic in Indonesia and get a free medicine, either metformin or amlodipine, to reduce the blood pressure. And this is very cheap generic products. But if you don't do anything, 5 years, definitely high probability you get stroke, kidney problem, or heart disease. So now our job is first to educate the people. Hey, you want to live long, 84 years old, or you love God so much, so you want to see God when you are 45. You make that choice. If you want to live until 79 or 80, see your grandchildren, then make sure you go to the primary care clinics, get a free, we just launched this year, a free birthday screening program. So every year, the government give you a birthday gift. What is the birthday gift? It's free checkup. A simple checkup, 19 items we check up, including blood pressure, blood sugar, and blood lipid, cholesterol level. If it is above, then we will give you free medicine, cheap, generic medicine, very, very cheap, in cents you are talking. But if not, then we will... then there is a high probability that you will die faster than your sisters or your brother. So that is the education that we are giving to the Indonesian population. Because for NCDs, the strategy is not to cure you when you are sick. The strategy is to keep you healthy. Keep you healthy means you have to do screening, and once you know your chart is off the chart, then you have to change your lifestyle. More physical activities, control what you drink, control what you eat.
So investments in primary healthcare, nutrition, and immunizations may seem like a big outlay at the beginning, but certainly less expensive and a better quality of
Better
life
quality of
than dialysis and radiation therapy and all these other issues that, especially with the geographic diversity of the country, might be challenging even for people to get to clinics for some of that care. So when you look at the global community around NCDs, I mean, countries are, still to some extent in different experiences in terms of where the demographics of the population, the age structure of the population and the degree to which they're experiencing these. But certainly all countries are experiencing some balance or level of dealing with infectious disease outbreaks along with the NCD issues. When you look ahead to September, and now this is the fourth meeting on this set of issues, what do you hope to see come out of it that would really kind of change the game for the next period?
Again, as NCD strategy should be geared toward promotive and preventive, I would like to see a clear movement from all government leaders that we have to shift our focus from curative, cure sick people, to promotive and preventive, to keep people healthy. Because to be honest, when I joined this ministry, 80% of my budget is allocated, 80% of my time is allocated to cure sick people. Talking about the doctors, talking about the specialists, talking about the hospital, expensive medical treatment, because they are where the money is. But that is for the producer, not for the people. For the people, we should focus our strategy in, the primary care, the midwife and nurses, the immunizations, how to expand the screening program, how to educate the people. This is to control what the sugar level that you should take, to limit the salt and limit also the fat, because otherwise when you keep, consuming sugar, and salt, definitely you will see God faster, because you get stroke and you get heart disease or you get kidney problem faster than anyone else. So that should be a very clear movement into this area. I will give you an example what I do in Indonesia. I'm 61. Last year I'm 60. And 60, it is a time where you can get free license, for life license, whatever it is. The Indonesian government give it to you. Yes, one side is good. The other side is intimidating, but because they are telling you, "Oh, you are old man. You're
not going to have to do this again."
You're old man.
Right.
So then I decided I want to run marathon. So I ran Berlin Marathon last year. This year, hopefully, I can go to Chicago Marathon. But the thing is, after I'm running marathon in 60, and I would like to finish the 6 majors in before 65, everybody said, "Hey, he's 60 and he want to live healthy." So that creates a movement. Healthcare programs, you cannot approach this as a program. We have to establish a movement where everybody feels that this is their responsibility. I want to live healthy. So that mechanics, usually politician is really good in it, to create people to believe that that is their job to be healthy. So I do hope this event in UNGA will start this movement, global movement, to make people healthy.
So maybe we'll see people,
Yes.
leaving Anga and signing up for the New York Marathon.
And I'm happy to see that you only serve water. This is a healthy way to do things, rather than put, sugar, whatever, juice or soda with sugars, which is not.
You could probably find coffee, but
Yes.
certainly around Washington this week, lots of coffee. Well, Minister Budi, thank you very much for joining me today. We've really covered a lot of ground from, kind of early childhood vaccines all the way to, really thinking about the importance of prevention as an economic investment in the health of people and the health of families, but really the health of society and the economic engine of a country, looking ahead over several generations. So Good luck to you in the remainder of your meetings here this week, and of course with the second global forum on cervical cancer elimination, and your work with Gavi, and at the fourth high-level meeting as well. Thank you very much for joining me.
Thank you, Catherine. I wish you all the health, long live, and I wish you that you can see your grandchildren married.
Well, thank you. I might have to start doing marathons in order to, to get there. Thank you.
Thank you.
Thanks very much.